Welcome to the Deep Dive. Today, we're really getting fundamental, tracing the path of the scalpel, from the moment a patient gets onto the operating table right through to that final secure knot.
That's right. We're diving deep into what's essentially the bedrock text for safe surgery. Chapter 7, Basic Surgical Skills, from Bailey and Love's Short Practice of Surgery.
If you're looking to really get your head around the core ideas, the things that define safe and, well, efficient surgery, this chapter is like the blueprint, isn't it?
Absolutely. It's not just a list of suggestions. These are, life-saving principles that have been refined over decades. Our goal here is to sort of distill these essential skills.
Make it easy to recall.
Exactly. A high recall guide, turning dense text into, well, practical know-how, nuggets you can actually use for revision or just to grasp the basics of how operations work.
Yeah, and we're covering a lot, from the mechanics of tilting the patient on the table to the physics behind diathermy and even connecting it all to complex stuff like vascular bypasses later on.
It's true. Mastering these fundamentals, that's the real core of surgical knowledge. This is your essential guide.
Okay, let's jump right in then, into the OR, so to speak. Where does it all begin?
Well, it starts before the first cut. It begins with preparing the environment and, crucially, the patient.
Right, getting the patient onto the table. You called it strategic patient positioning. Sounds like more than just getting them lying flat.
Oh, much more. It's not about comfort, not primarily anyway. It's about actively using the patient's position to get the best possible exposure for the surgeon, while also, and this is key, protecting them from accidental injury during the process.
So you're using gravity.
Pretty much, yeah. Gravity becomes a surgical tool. Think about two classic positions, Trendelenburg and reverse Trendelenburg.
Trendelenburg. That's head down, right. Feels counterintuitive.
It does, but it's absolutely essential for operations deep in the pelvis. If you tilt the patient head down, gravity just pulls all the intra-abdominal stuff, the small bowel, the omentum upwards.
The field's the field?
Exactly. It's like free retraction, mechanically. Invaluable.
And the source mentioned a really specific modern use for this.
Yes, in laparoscopic rectal surgery. For that tricky pelvic dissection deep down, you need that steep head-down Trendelenburg to keep the bowel clear. But then
you might need to work higher up.
Right. So you need to mobilize the transverse colon. You flip the strategy.
You go reverse Trendelenburg, head up.
Exactly. Tilt the patient head up, and now the organs shift downwards haughtily. This gives you much better access to the upper abdomen, makes mobilizing that transverse colon easier. It shows positioning isn't static. It changes based on what you need to do right now.
But tilting someone steeply for potentially hours? That sounds like it comes with risks. We need to talk about the complications.
Definitely. The risks fall into two main camps. Breathing problems, so respiratory compromise, and nerve injuries from traction.
Okay, breathing first. How does the tilt affect that?
Well, when you're head down, all those abdominal organs press up on the diaphragm. That can make it harder for the lungs to expand fully, especially the dependent lung. You might get what's called preferential ventilation. Most air goes to one lung.
Leading to problems in the other lung, like collapse?
Potentially, yeah. Atelectasis, or issues with oxygenation. And if the tilt is really extreme, there's even a small risk. The breathing tube, the endotracheal tube, could slip down into one main bronchus.
Wow, okay. And the nerve damage, that sounds particularly worrying. Permanent disability.
It's a devastating complication. The two nerves mentioned most often are the brachial plexus in the shoulder and arm and the ulnar nerve at the elbow.
How does the brachial plexus get injured?
It's usually stretch. The brachial plexus controls the arm and hand. It's vulnerable if the shoulder isn't padded right or if the arm is pulled back too far on an arm board. Or if the patient slides slightly down the table in that steep Trendelenburg, their shoulders can get caught, stretching the plexus.
Ouch. And the ulnar nerve. Is that pressure?
Yeah, usually direct compression. The ulnar nerve runs really close to the surface near the elbow, the funny bone spot. If the arm rests on a hard edge or isn't padded properly, that sustained pressure can damage the nerve. So meticulous padding everywhere is non-negotiable.
Okay, so positioning is critical. Moving on to the skin itself. Skin prep and planning the incision. Let's start with hair removal. There's a definite don't here, isn't there?
There is. The old way, shaving with a razor blade, is strongly discouraged now. The clear preference, because it significantly reduces surgical site infections, or SSIs, is using skin clippers. Specifically, clippers with disposable blades.
Why is shaving so bad for infection risk?
It's all about microtrauma. Even with care, a razor makes tiny little cuts and scrapes in the skin, micro-incisions. These are perfect entry points for bacteria.
Or they just make the skin more inflamed.
Exactly. Exaggerated inflammation, easier for bacteria to colonize. Clippers just cut the hair shaft above the skin, leaving the skin barrier intact. Much safer.
Skin prepped, hair removed, now planning the actual cut. We learned about Langer's lines, but the thinking has evolved.
It has. Langer's lines came from studying cadavers, showing how collagen fibers line up. But the modern approach focuses on something more dynamic. Relaxed skin tension lines, or RSTLs.
Relaxed skin tension lines. What's the difference in practice?
RSTLs show the direction of tension in the skin when the underlying muscles are relaxed. They basically follow the natural creases and wrinkles you see on the body.
And why cut along these lines? What's the advantage?
Two big ones. First, if your incision follows an RSTL, the wound edges tend to come together naturally when the skin is relaxed. Less tension on the closure. And tension is the enemy of good healing.
Okay, less tension. What's the second benefit?
Cosmetics, really. Scars along natural crease lines are much better hidden and much less noticeable. Think about the neck. A transverse cut along a neck crease heals way better cosmetically than a vertical one fighting against those lines.
Preparation done. Now we actually make the opening. Let's start with the traditional way, the classic open approach. Specifically, the midline laparotomy. This is the go-to for big exposure, right?
Yeah.
Especially emergencies.
It provides the widest access, but you absolutely have to know the layers you're cutting through. It's a precise anatomical journey.
So walk us through it, down the middle of the abdomen.
Okay. First, obviously, the skin. Then you go through the subcutaneous fat layer. The crucial layer next is the linea alba.
The white line.
Exactly. It's that tough fibrous band right down the middle where the big abdominal muscle layers fuse together. You incise vertically through that.
But the bowel is right underneath. How do you cut through that tough linea alba without instantly hitting something vital?
Well, that's where the careful technique comes in. Once you're through the linea alba, you expose the next layer, which is the peritoneum. It looks smooth, maybe a bit translucent.
And you don't just slice into that.
Definitely not. Before you make that final cut into the abdominal cavity, you do a critical step. You use 2 hemostats, those clamping instruments, one in surgeon's hand, one in the assistant's. You carefully grasp and lift the peritoneum.
Why 2 clamps? What does lifting it achieve?
2 things. First, it physically lifts the peritoneum well away from whatever's underneath. Could be bowel, could be omentum, gives you a safe margin. Second, with the tissue lifted between the 2 clamps, the assistant can visually check, make absolutely sure no bowel or anything else got accidentally snagged in the clamps.
Only then you make the cut.
Only then. Once everyone's happy it's clear, a small nick is made in the peritoneum. Then that opening is carefully extended under vision to get into the cavity.
That really shows the patience required, even when things are urgent. Which kind of contrasts with the move towards minimal access, like the modified Hasson's technique for getting that first port in.
Right. Laparoscopy, keyhole surgery is the standard for so many things now. Less trauma, faster recovery, usually. The Hasson technique is popular for that first entry point because it's an open technique.
Meaning you see the layers as you go.
Exactly. You dissect down and confirm visually that you're entering the abdomen, rather than using a blind poke method like with a Veress needle, which carries a slightly different risk profile for injury.
Okay, let's break down the Hasson's steps. Where do you usually start?
Typically the umbilicus, the belly button. The fascia tends to be a bit thinner there, and the scar hides nicely afterwards. First step is to avert the umbilicus, sort of turn it outwards slightly, then make a small cut right around or within it.
And you're aiming for a specific spot.
Yes, you're looking for the junction where the base of the umbilical stalk meets the linea alba. That's your target.
What exactly are you cutting there?
You're looking for the decussation, that spot where the tough fascia fibers interweave and cross over. You take an 11-blade scalpel, the pointy one, and make a small vertical cut just through those fascial layers.
Just the fascia, not deeper.
Critically, yes. Just incise the fascia. You want to open that tough layer, but ideally leave the peritoneum underneath intact for the moment.
Okay, fascia's open. How do you get through that last layer, the peritoneum?
Once the fascia's open, you switch to a blunt instrument. Often it's a closed hemostat, the blunt end. You gently push this through the fatty tissue just above the peritoneum, the preperitoneal fat, and then through the peritoneum itself.
And you feel something.
Yes. There's usually a distinct pop or give as the tip finally breaks through the resistance of the peritoneum and enters the abdominal cavity. That tactile feedback confirms you're in. Then immediately you slide the blunt-tipped primary trocar, the first port, through that same opening.
And before any of this starts, especially before inflating the abdomen with gas, the pneumoperitoneum. There's a crucial safety check.
Absolutely vital. Two things, really, to reduce the risk of injuring organs. First, confirm the patient has fasted properly. A distended bowel is much easier to accidentally injure. Second, and very important just before starting, confirm the bladder is empty.
Why the bladder specifically?
A full bladder balloons up and can be right in the path of that initial trocar insertion, especially if you're going in low down near the pelvis. Emptying it is mandatory to avoid puncturing it.
All right, we're in. Surgery's done. Now we need to close up meticulously. We're shifting gears from cutting to rebuilding. Let's talk suture selection and needle geometry. Choosing the right thread and needle.
Yeah, it's a mix of art and science. You're balancing how long the tissue needs support against how quickly the suture material breaks down or gets absorbed by the body. We broadly group them. Natural absorbables like catgut.
Which breaks down really fast.
Very fast tensile strength loss. Then you have synthetic absorbables, Vicryl, PDS, monocryl are common examples, and finally non-absorbables like nylon or Prolene, which stay put pretty much permanently.
So let's compare. Say monocryl versus PDS. What's the practical difference? When would you use each?
It's all about the tissue's healing time. Monocryl is great for things that heal quickly, like skin or the fatty layer just beneath it. It loses most of its strength in maybe a couple of weeks and is gone fairly fast.
Okay, so short-term support. What about PDS?
PDS is for the long haul. Think tough tissues that heal slowly, like the fascia, that strong layer we cut through in the midline, or maybe in situations where healing might be delayed. PDS keeps its strength for much longer, maybe 6 weeks or more, and takes ages, like 6 months to a year, to fully absorb. It has to hold things together until the body's own repair is solid.
And the needle attached to the suture, that's not just random, is it? The shape matters.
Absolutely. The needle geometry is chosen based on the tissue you're trying to pass through. Think about resistance.
Okay.
For tough, dense stuff like skin or that fibrous fascia, again, you need cutting needles. They have sharp, often triangular edges designed to slice a path through resistant tissue easily.
Makes sense. And for the softer, more delicate layers?
There you want round-bodied needles. They don't have sharp cutting edges. They're designed to gently spread or separate the tissue fibers as they pass through, rather than cutting them.
Less trauma.
Exactly. Minimizes bleeding and tissue damage, which is vital in, say, bowel surgery or closing the peritoneum. Oh, and most modern sutures are swaged.
Swaged, meaning the thread is fused onto the needle.
Right. The suture is permanently attached directly to the end of the needle. It makes the whole thing smoother, reduces the size of the hole needed for the thread to follow the needle, less drag, less tissue trauma again.
Now, actually putting the stitches in. Mastery of suture techniques. Let's start with interrupted sutures, the individual ones. There's a specific geometry to get right.
There absolutely is. It's quite mathematical, actually. The basic rule for an interrupted stitch relates how deep you take the bite of tissue to how far you are from the wound edge.
Okay, depth and distance.
The distance from where your needle goes into the tissue to the actual wound edge should be roughly the same as the depth of the tissue bite you're taking with that stitch.
Why is that specific ratio important? Depth equals distance.
It ensures that when you tie the knot, the wound edges come together perfectly, edge to edge, and importantly, the deeper parts of the wound are also brought together, eliminating any empty space underneath.
Dead space.
Exactly. If your bites are too shallow, you leave a gap deep down where blood or fluid can collect a hematoma or seroma, which invites infection. Too wide, and you might pull too tight, cut off blood supply.
And spacing between stitches. How far apart should they be?
The rule of thumb is that successive stitches should be placed about twice that initial distance apart. So if your bite was 5 millimeters deep and 5 millimeters from the edge, the next stitch should be about 10 millimeters further along the incision.
Creates even support.
Yes, distributes the tension evenly. And one more thing, the needle should go in at a right angle, perpendicular to the skin or tissue surface to get a good, solid bite of tissue.
You keep mentioning tension. Is there one big principle for all closures?
Right.
And any tissue to definitely avoid including?
The absolute #1 rule, the overriding principle for any closure, is tension-free approximation. Cannot stress that enough.
Why is tension so bad?
If the closure is tight, it squeezes the blood vessels in the wound edges. That reduces blood flow, causes ischemia. Ischemia means poor healing, higher risk of the wound breaking down, dehiscence, and much higher risk of infection. And yes, there's one tissue layer you must actively try not to include in your main deep closure stitches: subcutaneous fat.
The fatty layers just under the skin. Why avoid that?
Fat has a relatively poor blood supply compared to muscle or fascia. If you crush fat tissue in a suture, especially under tension, it's very likely to die to necros.
And dead fat is bad news.
Very bad. Necrotic fat is a perfect breeding ground for bacteria. It dramatically increases infection risk. That's why surgeons often close in layers, secure the strong fascia layer first, taking the tension, then close the skin more gently above it.
Are there times when you don't need stitches at all? Like for small cuts, especially somewhere visible?
Yes, definitely. For clean, straight cuts under very low tension, particularly on the face, you can use things like skin adhesive strips, Steri-Strips, or special medical glues, tissue adhesives.
Better cosmetic result.
Often, yes. They hold the edges together without the little puncture marks from needles or the inflammation sometimes caused by suture material itself.
Okay, what about continuous sutures? The running stitch.
Yeah.
Often used for closing fascia, right? Because it's faster.
It is faster, yeah. One long thread running along the incision. But managing a long, continuous suture, like closing a whole midline laparotomy incision, needs care to keep the tension even and make sure you can see what you're doing.
Is there a trick to that?
A common technique is to start two separate continuous sutures. One starts at the top end of the incision, the other starts at the bottom end, and you run them towards each other until they meet in the middle.
Ah, so you're not trying to manage one massive long suture line.
Exactly. It helps balance the tension across the whole wound and makes it easier to see exactly where your needle is going, ensuring you get good bites of fascia all the way along without accidentally catching anything else.
And then the final step of any stitch, the art of knotting.
It sounds simple, doesn't it? Tying a knot. But it is absolutely fundamental. A badly tied knot, one that slips or comes undone or is maybe tied way too tight, strangling the tissue can completely undo an otherwise perfect operation.
So the knot has to be just right.
It has to be square, secure, locking the approximation without clinching the tissue. It's a core skill.
Okay, closing up assumes we've controlled any bleeding. Hemostasis. Keeping the field clear is essential. The source classifies bleeding based on when it happens, which seems important for spotting problems later.
Yeah, that timing classification is really useful for thinking clinically. First type is obvious. Primary hemorrhage. That's just bleeding that happens during the surgery itself.
And the surgeon deals with it right there. Clamps, ties, diathermy.
Exactly. You see it, you stop it. The next two types are postoperative complications. Let's talk about reactionary hemorrhage.
Reactionary. Sounds like it's reacting to something.
It is. It typically happens in the first day or two, maybe 24 to 48 hours after the operation. And it's usually related to the patient waking up, their body getting back to normal.
How so?
Well, during the surgery, the patient might have had slightly lower blood pressure or their blood vessels might have been a bit constricted. When they wake up, their blood pressure comes back up to normal, maybe even spikes a bit, and vessels dilate.
And that causes bleeding.
It can. A tie, a ligature that was secure when the pressure was low might slip off, or a small vessel that wasn't bleeding noticeably during the op because it was constricted might start bleeding properly once the pressure rises and the vessel opens up.
Ah, okay. So the bleeding reacts to the improved blood pressure. What about secondary hemorrhage? That sounds more serious.
It is much more serious and thankfully rarer. Secondary hemorrhage happens later, days or even weeks after the operation, and it's almost always a sign of a deep infection.
Infection causes bleeding.
Yes. The infection sets in, maybe forms an abscess, and the inflammation actually erodes through the wall of a nearby blood vessel, often quite a large one. This type of bleed can be sudden, massive, and life-threatening. Needs urgent intervention.
Scary stuff. Now, the main tool surgeons use to prevent bleeding, and also to cut, is electrosurgery diathermy. Let's get into the physics of diathermy. Big difference between monopolar and bipolar, right?
Huge difference in how the electricity flows. In monopolar diathermy, you're essentially making the patient part of the electrical circuit.
How does that work?
You have the active electrode, the tip of the diathermy pencil or forceps where the energy is concentrated. The current flows from that small tip through the patient's body to a large sticky pad placed somewhere else on their body, like the thigh or back. That's the patient plate or dispersive pad.
And the big pad stops them getting burned where the current exits.
Exactly. The current is intense at the tiny active tip doing the cutting or coagulating, but it spreads out over the large surface area of the pad, so the current density is very low there, preventing burns. Now, bipolar is different.
How so? Confined current.
Precisely. Bipolar usually uses special forceps where both tips act as electrodes. One delivers the current, the other is the return path. The electricity only flows between those two tips directly through the small bit of tissue grasped in the forceps. The current path is very localized.
And you can adjust the type of current for different effects.
Yeah.
Cutting versus coagulating.
Yes, the machine generates different electrical waveforms. For cutting, you want a clean slice. The machine delivers a relatively lower voltage, but crucially, it's a continuous current. It's on 100% of the time.
What does continuous current do to tissue?
That constant high-density energy heats the water inside the cell so rapidly it basically explodes, flash vaporizes. That creates the cut.
And for coagulation, you want to seal vessels, not explode them.
Right. For coagulation, you need to heat the tissue more slowly, dry it out, desiccate it so the proteins denature and the vessels seal. To do that, the machine uses a higher voltage, but it's an interrupted current.
Pulsed.
Exactly. The source says it's typically on only about 6% of the time and off for the other 94%. This pulse delivery cooks the tissue rather than vaporizing it, shrinking it, and sealing the small bleeders.
Okay, so Monopolar sends current through the whole body. That leads straight to the big safety warning about implantable devices.
This is a massive safety issue. That electrical current flowing through the body, especially if it crosses the chest, can seriously interfere with or even damage electronic implants. We're talking pacemakers, implantable defibrillators, ICDs, even things like cochlear implants.
So you have to know if a patient has one before using diathermy.
Absolutely non-negotiable. Before surgery, you must check for any implanted devices. If they have one, you usually need to consult with cardiology or the device specialists. The device might need to be reprogrammed temporarily or monitored very closely during the procedure.
Are there safer alternatives if someone has a pacemaker, for instance?
Yes. Bipolar diathermy is much safer because the current is confined locally between the forceps tips. It's far less likely to interfere. Another great option is the ultrasonic scalpel devices like the harmonic scalpel.
How does that work? No electricity.
Correct. It uses high-frequency mechanical vibrations, not electrical current, to cut and coagulate tissue simultaneously. So zero risk of electrical interference with implants. Very useful tool in those situations.
Okay, we've laid down the fundamental skills: positioning, cutting, closing, controlling bleeding. Now let's see how these basics apply in more complex scenarios, starting with surgical planning, insights from arterial disease.
Vascular surgery is a great place to see these skills tested. Treating peripheral arterial disease, blocked arteries in the legs, often needs major bypass operations. Think about an aorta bifemoral bypass.
Going from the aorta down to both femoral arteries in the groin? That sounds like a huge operation.
It is. Major abdominal incision, extensive dissection deep inside. It really demands flawless application of all those basic principles. Careful dissection, perfect hemostasis, and a rock-solid closure afterwards.
And the source mentions the risks are pretty significant.
They are. For an aorta bifemoral bypass, typically using a synthetic Dacron graft, the risk of dying around the time of surgery, perioperative mortality, is quoted around 5%. And the risk of other major problems, heart attack, lung issues, kidney failure, systemic morbidity, can be as high as 15%. That massive wound needs an incredibly strong fascial closure, often with a non-absorbable suture like Prolene, to hold up.
What if someone is just too sick or frail for such a big abdominal operation? Is there an alternative?
There is, though it's maybe not quite as good long-term. For patients deemed unfit for the big abdominal approach, surgeons can do an axillobifemoral bypass.
Axilla from the armpit.
Exactly. The graft runs from the axillary artery under the arm, down the side of the chest and abdomen, tunneling under the skin to connect to the femoral arteries. It avoids opening the abdomen completely.
Lower risk for frail patients.
Generally, yes. Lower immediate morbidity. The trade-off is that the results, in terms of how long the graft stays open, patency, tend not to be quite as good as the direct aortobifemoral route.
Okay, what about bypasses lower down, say, from the femoral artery in the thigh to the popliteal artery behind the knee? Femoral-Popliteal bypass. Material choice is key there, isn't it? Conduit quality.
It's everything for long-term success. The evidence is really clear on this. For fem-pop bypasses, the absolute best conduit, the one that gives the best long-term patency rates, is the patient's own great saphenous vein, GSV.
Using their own vein.
Yes. Harvested carefully, reversed so the valves don't obstruct flow. Nothing beats the biological compatibility of the patient's own tissue for lining a blood vessel. Synthetic just don't match up over time.
But what if their vein isn't good enough? Or maybe it's already been used for heart bypass surgery. You have to use a synthetic graft then, like PTFE.
Right. If autologous vein isn't an option, you often turn to prosthetic grafts, commonly PTFE. polytetrafluoroethylene. But we know the patency rates with PTFE are lower than with vein. So surgeons try little tricks to improve things.
Advanced graft techniques.
Exactly. Specifically at the join between the synthetic graft and the artery, lower down the distal anastomosis techniques like the Miller cuff or the St. Mary's boot can be used.
That's those. Sounds like footwear.
Yeah. It's basically taking a small patch or collar of the patient's own vein, if available, and sewing that onto the artery first. Then you sew the synthetic PTFE graft onto that little patch of vein instead of directly onto the artery.
Like an interposition piece.
Precisely. The idea is that this little cuff of vein creates a smoother transition, maybe improves the flow dynamics where the stiff synthetic meets the natural artery, and hopefully reduces the turbulence and tendency for clotting or narrowing right at that crucial join. It's a neat combination of synthetic tech and biological finesse.
Let's link back to incision planning. Knowing where to cut often depends on knowing exactly what's wrong inside. That brings in imaging synergy.
Absolutely. Anatomy knowledge is one thing, but pinpointing the pathology relies heavily on modern imaging, especially in abdominal emergencies like bowel obstruction.
And CT scans are king here.
For suspected bowel obstruction, CT is now really the first choice, much better than older contrast studies like follow-throughs or enemas, particularly when things are acute.
What's the key thing the CT shows the surgeon?
It finds the transition zone. That's the exact spot where you see the bowel upstream is dilated, full of fluid and gas because it's blocked, and then abruptly the bowel downstream is collapsed and empty. Seeing that transition point confirms there's mechanical blockage and often tells you where it is and maybe even why. That guides your whole surgical plan, including where to make the incision.
And CT is especially vital for a really dangerous type of obstruction, closed loop.
Critical for diagnosing that. A closed-loop obstruction is when a segment of bowel is blocked at 2 points close together, trapping the bit in between.
Like twisting it.
Could be a twist or trapped in a hernia. Because that trapped loop has no way out for gas or fluid, the pressure inside builds up incredibly fast. This squeezes the blood vessels in the bowel wall, cutting off the blood supply, leading to ischemia, necrosis, perforation. It's a true surgical emergency.
How does CT spot that?
You see the classic signs of obstruction, but then you might see a segment of dilated bowel leading into a transition point, but then beyond that point, there's another transition point where collapsed bowel begins again. That C-shape or U-shape of dilated bowel trapped between 2 points is the hallmark. Needs surgery urgently.
Okay, one last connection. Back to minimal access surgery. Even with tiny incisions, the need for precision, especially anatomical precision, is paramount, near the gallbladder, for instance.
Oh, definitely. Laparoscopic cholecystectomy, taking the gallbladder out keyhole, is super common, but there's bad inflammation, the normal landmarks can get really messed up. Damaging the main bile duct, the common bile duct, CBD, is the nightmare scenario.
So surgeons use mental maps or strategies. The source mentions be safe.
Yes. Be safe is a mnemonic, a memory aid, to help the surgeon stay oriented, particularly to the structures behind the area they're dissecting, it stands for. Bile duct, which you want to avoid. Sulcus of Rouvier, a key landmark groove on the liver. Hepatic artery, umbilical fissure, another liver landmark. And enteric duodenum, the bowel nearby.
How does knowing those landmarks help avoid injury, specifically the sulcus of Rouvier?
The sulcus of Rouvier is this reliable groove on the underside of the right liver. The critical insight is that the common bile duct almost always lies posterior behind and deeper than an imaginary line drawn from that sulcus across towards the base of liver segment 4.
So stay in front of that line.
Basically, yes. Keep your dissection ventral, meaning anterior and superior to that line, sometimes called the R4U line, Rouvier to segment 4 base via umbilical fissure. Staying above and in front of that plane significantly reduces the risk of accidentally grabbing or clipping the CBD in a difficult dissection. It's a fantastic example of combining technical skill with deep, applied anatomical knowledge.
But even with all these safety measures, things can still go wrong, or plans might need to change, which leads to informed consent for minimal access. Patients need to understand the possibilities, right?
Absolutely. Consent isn't just signing a form, it's ensuring understanding. Patients undergoing laparoscopy need to know there's always a chance it might need to be converted to a full open operation if there's unexpected bleeding, or the anatomy is just too unclear to proceed safely keyhole.
And they need to know about common minor issues, too.
Yes, things like shoulder tip pain are really common afterwards.
Why does that happen?
It's referred pain. The CO2 gas used to inflate the abdomen irritates the diaphragm muscle at the end of the case, and the phrenic nerve, which supplies the diaphragm, shares nerve roots with nerves supplying the shoulder tip. So the brain interprets the irritation as shoulder pain. Weird, but common.
Anything else common?
Minor surgical emphysema, a bit of the CO2 gas tracking under the skin, feels a bit like bubble wrap that can happen too. And crucially, they must also understand the rare but serious risks accidentally injuring bowel or a blood vessel with that first trocar, or maybe a burn from stray diathermy current. Full transparency is key. #tag outro.
Wow, we have covered a huge amount there. Really drilled down into those fundamental skills, the how-to of safely getting into the body, working inside, and closing up properly. Let's try and sum up the absolute core messages.
Okay, I think number one has to be respecting tissue tension. That means planning incisions along RSTLs, getting that suture geometry right, depth equals distance, spacing twice the distance, and above all, ensuring every closure is absolutely tension-free.
Right, and the power tools, like diathermy.
Vigilance is key. Know the difference. Continuous low-voltage current for cutting by vaporization versus pulsed high voltage for coagulation by desiccation. And that critical safety check for pacemakers and other implants, use bipolar or ultrasonic if there's any doubt.
And good planning underpins it all.
Definitely. Careful patient positioning avoids nerve injuries. Pre-op imaging, like CT for bowel obstruction, finds that crucial transition zone and guides the whole approach. Preparation defines the outcome.
Now, looking beyond the techniques themselves, surgery, any major injury really, puts the body under immense stress, doesn't it? There's a bigger physiological picture.
There really is. Major trauma or extensive surgery triggers what we call a profound catabolic stress response. The body basically starts breaking itself down auto-cannibalism to find fuel and building blocks for repair.
And you can measure this.
You can see it in the nitrogen balance. Patients lose huge amounts of nitrogen in their urine, often 10 to 20 grams of nitrogen per day.
That sounds like a lot. What does that mean in terms of actual tissue?
Well, 10-20 grams of nitrogen loss equates to breaking down roughly 500 grams, half a kilogram of lean body mass, mostly muscle, every single day.
Half a kilo of muscle loss a day. That's staggering.
It is. And understanding that massive physiological cost is why minimizing the surgical insult, using minimal access where possible, good pain control, aggressive nutritional support afterwards is just as important for recovery as the surgeon's technical skill during the operation itself.
Okay, that leads us nicely into our final thought. We've talked a lot about the technical how-to, but what really marks out a truly great surgeon isn't just the hands-on skill, is it? It's something more.
It's the clinical judgment, the acumen. It's knowing when and why to use those skills and recognizing when something subtle is going wrong. Think about acute compartment syndrome again.
Right, the pressure buildup in a limb compartment.
We know the context crush injury may be a fracture, but spotting it early is tough. The key signs are subtle at first, pain that seems way worse than the injury should cause, and the real clincher, severe pain when you passively move the muscles in that compartment. Gently stretching them is agony.
And missing that.
Missing that, delaying the diagnosis and the emergency fasciotomy, the operation to release the pressure, means the muscle tissue dies from lack of blood flow. Irreversible damage, permanent disability. So the ultimate test isn't just tying the perfect knot, it's integrating all that basic science, anatomy, physiology, and using it to read the subtle clinical signs to recognize that surgical emergency before it's too late.
A powerful reminder. Technical skill needs clinical wisdom. Well, thank you for that incredibly detailed walkthrough. That was fantastic.
My pleasure. It's crucial stuff. Thanks for joining us on this deep dive.
We'll catch you next time.